nursing school, and then a Michigan Health Corporation. The health system revenue is around $3 billion a year. We have about 990 staff beds and employ about 26,000 people. So it's a big operation. If you start to think about it in terms of a Fortune 500 company, it wouldn't reach to that levels, but it's a fairly big enterprise. We do about 1.8 million visits in the outpatient clinics. All the physicians that would do these visits are employees of the University of Michigan. It's somewhat of a closed medical shop, so everybody who works for the health system and sees patients there has an appointment in the medical school. 44,000 discharges, 81,000 emergency room visits, 46,000 operations, 1,200 survival flight missions. So that's our helicopter service. That's well renowned. They've won lots of awards across the country. And we're now starting to do survival flight helicopter missions for other hospitals in the area because it's quite expensive, and we do it so well. We're actually going out, picking up patients and flying them to another hospital to help those hospitals as well. And about 4,000 deliveries a year, you can see on the bottom. So that's for the Voigtlander Women's Hospital. A lot of babies get delivered there, and that's a fair number of births as well. Our mission at Mott and Voigtlander is to integrate the clinical care, the education of all the trainees. That's a big part of our mission. Research and advocacy to advance the health status of children, women, and their families, as well as the communities, and to do that across the entire state. This is just not an Ann Arbor, Washtenaw County business. Our history is in 1901. A gentleman by the name of Love Palmer gave $20,000. I wonder if you could build something for $20,000 these days, what you'd get, to build one of the first children's wards in what was then University of Michigan Hospital. We have the first child life program. I don't know how many of you are familiar with child life programs, but that's where we have staff that actually come in and work at the bedside or in rooms with child activities, teaching, games and stuff like that in order to help keep the kids occupied during their visits. We were the first program in the country to do that, and that was back in 1922. In 1969, C.S. Mott Children's Hospital, the old Mott that Brian referred to, was opened due to a generous gift from the Charles Stewart Mott Foundation in Flint. And then a maternal child health center. We expanded the old Mott a little bit in the early 90s. We have a tradition of excellence. In fiscal year 2011, Mott earned the highest rankings in the state of Michigan and among the best in the country in U.S. News and World Report status. We're fourth in heart and heart surgery. The Department of Pediatrics is ranked 7th nationally in National Institute of Health Funded Research Activity. We think that's going to go up. We should make it into the top 5 this year. And that's important. That NIH dollars that we get to come back, that supports large numbers of other investigators and employees and stuff in the state. It's with good jobs. The Women's Health Program ranked in the top 10 in U.S. News and World Report, and the OVPGR department ranked 18th in the country. Here's the most recent U.S. News and World Report rankings. We're the only children's hospital, obviously, in the state to get ranked in all these areas that U.S. News and World Report ranks us. You can see that some of these numbers for 2012 look a little bit worse than our 2011 numbers. And that's in part because they changed the scoring system on us, and they went by reputation more than by some of the other quality metrics that we're proud of. We do quite well in the quality metrics and the structure metrics, but not as well on the reputation one as some of the more well-established children's hospitals like Boston Children's Hospitals and others. Multidisciplinary partnerships. Now, Brian talked about this as well. How do you get different groups together of providers, different doctors, nurses, respiratory therapists? And this is a long list, but you can go down to one of the areas near and dear to my heart as a gastroenterologist is the intestinal rehab program. If you don't have all your intestines, how do you live? You need it to grow as a child. And we have programs where we put IVs in you and leave them in, send you home with food going through your IVs, and work with the families through home care programs to get that done. Transition programs if you have lung disease, the congenital heart program, bone marrow transplant, liver transplant. You can see it's a long, long list of very specialized programs that people from all over the state and indeed all over the country and sometimes the world come to us for. Medical services. It's the full range. Just about anything you want to do, we can do at Mott. There's a couple of things we don't do, and we'll send out, but the vast, vast majority of anything the child might need, we can do at Mott. You can see all the services listed above, and then below some unique ones, the bone marrow transplant program, fetal intervention programs. This is where we get teams of doctors, nurses from both obstetrics as well as pediatrics that might decide to do an operation on a baby while still in the womb. So you can imagine then you get a whole team of doctors in the room, somebody to put the mom asleep, somebody to monitor the mom, somebody to monitor the baby. The obstetrician goes in, opens up the womb, then we come in with the pediatric surgeon comes in and does an operation in the baby, and then we close everything back up, close the wound on the baby, close the womb back up, and take the mom back to the ward where we then again monitor the baby and the mom simultaneously so that the baby can then grow and develop in the womb. So those are unique programs. So we serve Michigan and beyond. You can see where some of our discharges come from. Obviously about 31% come from what the blue counties here, which is Washtenaw and Livingston County. You would expect that. That's where we're located. But 39%, that's almost 2/5 of our admissions, come from greater southeast Michigan. It's in that red area. And 26% come from outstate. So a quarter of our stuff comes from the rest of the state. So we provide services all over the state. And 4% of our admissions actually come from outside the state of Michigan. We have clinical outreach and affiliations and partnerships with hospitals all over the state. You can see them here. Flint, here in Lansing, Toledo, Traverse City, Kalamazoo, Grand Rapids, and in southeast Michigan at Beaumont and Trinity Health. Here's some of the examples. We have genetics clinics in the Upper Peninsula, multi-CMS clinics all over the state, newborn screening with pediatric endocrinology in those areas that you saw listed before. Telemedicine services, this is something else we've been trying to do. The governor's been excited about this. We'll read your echocardiogram. So if you happen to be in a remote area, let's say in the northern lower peninsula, the upper peninsula, and you have an echo done, and you want to get it read by a pediatric cardiologist, we'll do that via telemedicine. We also do epilepsy via telemedicine. So if you have seizure disorder and you're in Alpena, and you want somebody to read your EEG, we'll do that electronically. Here's a zip code analysis. So this just looks statewide at where we see patients. And obviously the dark green, I don't know why we picked green. I don't like that color. But the dark green is the ones where we get lots of discharges from. But every state, every county in the state, in any given year, we'll look after some patient from that area. Quality and safety initiatives, there's lots of those. We participate or lead several important quality improvement efforts. We want to try to reduce the harm that can come to children. And we call those hospital-acquired conditions, or sometimes referred to as HACs. Those include pressure ulcers, bloodstream infections from IVs being in, surgical site infections. If you're on a ventilator, we don't want you to get a pneumonia because we caused it. So we call that ventilator-associated pneumonia, and medication errors. Medication errors are particularly problematic in kids because of the wide ranges of sizes. Most drugs are dosed upon size. So it's very easy to make a mistake in a child compared to an adult. We have family members. So this is the part that Brian talked about a little bit. Not only were they involved in the design of the hospital, we have family members sitting on all our important committees. Our Mott Executive Committee. There was some controversy about should we have a family member sit on our safety committee where we talk about mistakes we've made. And the answer is yes, it's very valuable to have family members there. They actually bring a fair amount of heat to the equation for us, which is really good. It's hard to sit in a room when you have a family member there and debate about what you should do to fix the problem. They're basically sitting there, fix it. This should not happen to another kid. And it's been very helpful for us. We have clinical practice guidelines that we're developing. Other institutions are picking them up. And we're standardizing the care using lean principles that you may have heard about in other industries. Doing innovation as well on safety. We deliver medications to the bedside rather than having them go to a med room where a nurse then has to run off to this medication room perhaps and leave a patient in the ICU. If I put an order in the computer for a medication, that medication electronically goes to the pharmacy mixes it up, and it shows up at the bedside with the nurse still in the room to give to the patient. So it's much quicker. It's reduced errors and markedly improved delivery times. We have a new system now where monitors, you get hooked up to a monitor, you hear the beep, beep, beep that you see on television. Rather than have that just beep an alarm, they'll actually send a signal now into the nurses all have a phone, and they'll actually tell them on the phone what type of alarm it is. And if a nurse can't get to the patient right away because she might be tied up with another patient, and that alarm isn't taken care of, then it fans out to another group of nurses or respiratory therapists or whatever nearby, so that eventually that alarm always gets answered. We also have a new 42-inch flat panel TVs in every room, and they're not just for us guys to watch ESPN. They actually are loaded up with a Get Well network, and that Get Well network has all sorts of educational information for families, has videos for video games for kids of all ages, and it's been used extensively by our families. We have access improvements. One of the complaints sometimes people have is it's hard to get into U of M. We now have a 24-hour-a-day, 7-day-a-week, what we call an admitting doctor of the day. So if any doctor in the state says, I've got a patient in the hospital, I want to get in there, they pick up the phone, dial that 1-800 number, they can ask for advice, and they'll immediately talk to a senior level physician to facilitate the transfer, perhaps by our helicopter service. That helicopter service, by the way, Survival Flight has a couple of new helicopters, which will enable us to go anywhere in the state, even to the distant reaches of the UP, much more quickly. They're faster, and they have a much better fuel range. We used to worry a little bit about going to Marquette, depending on what the winds would look like without refueling. We don't have that issue anymore. Now, the other thing we have, which is really unique for children's hospitals, you hear about standalone children's hospitals being so good. We have the Women's Hospital and the Children's Hospital in the same building. So that means then if a mom has a baby that has a problem and delivers prematurely, that baby doesn't have to get shipped in an ambulance to another hospital. That can all be done right there. So we have in-house 24/7 coverage with a senior level obstetrician. Same thing for the neonatologist to look after your baby. So then there has to be, obviously, with that physical proximity, it drives a close collaboration between obstetrics and pediatrics. And that's critical for fetal programs. So if you get that ultrasound at 20 weeks like Brian did, you know your kid has a heart defect, you don't want to deliver your child at a hospital who can't look after that heart defect because it may need medication stabilizations or maybe even an operation within the first few hours after life. We can do that. So we actually set those things up where the mom delivers and we know the baby's going to deliver, and then we do an operation. Sometimes before even we deliver the placenta. Sometimes the baby comes out, we hook the baby up to an instrument or something, do some part of an operation, and then finish the delivery, deliver the placenta, unhook the baby from the umbilical cord, and then take him to the neonatal intensive care unit. We share what we know. We have Your Child podcasts. We have a national poll on children's health. So we have a great health comes and health services research organization that gives us data on what's going on in the world so we can poll the nation to find out how do people really feel about children's health issues. And we use this a lot, and this gets published a lot in the lay press. What kind of new things are we doing? Well, we're using knifeless ultrasound therapies. We're doing what they call melody valves, which is if you need a heart valve replaced, previously that would require you to have that done with an open heart surgery. We can now do that through a cardiac catheterization. We have a hybrid cardiac surgery program where we're going to be able to do more and more of these cases, where a cardiologist can be in the room, do stuff with a catheter, and a surgeon can be there as well. Muscular dystrophy clinics, intestinal failure I mentioned, sleep medicine, and MR-OR. So we have, when's that going to open, Loree? In July, December? So we'll have that MR-OR open for brain tumors primarily, so that a surgeon, if you're going to have your brain tumor operated on, you can see the tumor easily on the CT scan. But when the surgeon goes and takes your skull off and looks at your brain, they can't see what's tumor and what's normal brain. And of course, if it's your brain, you would really like the surgeon to take the tumor out and leave your normal brain behind. And not leave any